Great pleasure to introduce our next speaker, Quyn. Aaron is Associate Professor of Surgery at University of Leeds and is also very involved with the UK Pelvic Centration Group, and so understands the pelvis better than most of us. When we see a presacral tumour on a CT scan, most colorectal surgeons quake, don't know what to do, and are very relieved that there's somebody who does. So thank you for talking to us about that.
Thank you. So I've been asked to talk today about the development of an international consensus on the management of presacral tumours, why it is necessary, how we went about and structured it, and how we hope that this will make an impact on the management of patients moving forward. Now imagine this, a large pelvic tumour that is sitting on or very close to within millimetres of sacral nerves, the iliac vessels, displacing the pelvic floor, and tethered to the rectum or the vagina, and the impact that this could potentially have on the patient, be it one wrong decision in an MDT, some uncertainty in the operating room, can mean the difference between continence and permanent dysfunction, recurrence versus a clear margin, or nerve preservation or chronic neuropathic pain. And so the definition of presacral tumours has evolved over recent years. It used to, or historically, it focused on those that were congenital, but now it's this more inclusive definition that really arises in this group, this space that includes fat, nerves, blood vessels, and it's really these totipotential cells that can generate a large number of tumours. And this all-inclusive definition really aligns itself to the necessary multidisciplinary approach. And the real need for a consensus is because these tumours are rare. They are very rare. 1 in 440,000 hospital admissions with over 70 distinct tumour subtypes. And these patients often present with a variety of symptoms, with a lot of them presenting asymptomatically. Now, what that actually means is the majority of clinicians will see a handful of cases throughout their career. And it's this rarity that poses the biggest problem, in that no one surgeon or centre will see enough of these to really gain that experience or wisdom to generate best practice. And this kind of translates into what we see in the world published data. And this is what is out there from largely single centre series. We see a resection margin positivity rate that varies hugely between 40 and 90%. We see morbidity varying between centres of 15 to 50%, depending on approach. But we also see a huge variety of nerve-sparing techniques and the functional outcomes that can be associated with that. But what's most alarming is that there is no agreed consensus on those patients that actually require an operation and which ones can be managed non-operatively. And so the gaps that have been identified, as I've said, this is largely the data that we have, and our knowledge is largely based on single centre data set studies. We have almost nothing on the prediction of functional outcomes. We don't know that much about the non-operative management or how these patients should be worked up in the diagnosis of these tumours. And what we know is that across the globe, there is this wide variation in the management. And so today I'm here standing on the shoulders of giants. This study has largely been led by these two gentlemen here, Will Perry and Eric Dozois from the Mayo, but it's a consensus group that's been put together from the tripartite globally. And what we've done is we have procedures globally. And what we've done is we have generated these 9 domains listed here, where we've looked at the definition and classification, the assessment, the role of the multidisciplinary team, the variation in the operative approach, how neoadjuvant or adjuvant strategies can be used, what outcomes and functional data we should be looking at, and how these patients should be followed up, both in normal and in recurrent cases, with special consideration for those more rare special tumours. And this has generated 22 statements. Now, going through those statements in great detail today is beyond the scope of this talk, but I will provide a QR code at the end for those that are interested to look and certainly comment and provide feedback before it goes for final publication. And so we did a modified Delphi consensus with thematic work streams. In an international roundtable, we identified those 9 domains, and each domain was allocated to a specialist centre. Those specialist centres were then responsible for generating evidence-based or experience-based statements, and then it's been through several rounds of iterative consensus. And what we've achieved, well, we now have a clear diagnostic pathway. We have defined recommendations for the MDT. We have provided guidance on the indications for biopsy, which again from the literature varies hugely across the globe. We've standardized the imaging recommendations and provided guidance on those tumours that can be managed and surveyed non-operatively. We've provided some structured decision-making for the surgical approaches adopted, and recommended the functional outcomes along with the oncologic outcomes following these operations. But most importantly, we have provided for the first time a roadmap for safe, consistent and high quality management for this very rare patient group. But the consensus is not the final destination, it is a platform. And it's really from here and by bringing together or standardizing the management globally that we can really build on and develop prospective data sets that will hopefully allow better quality assurance, but also permit international collaboration where those very rare tumours can be examined or studied in greater detail. And it also could potentially lend to the development of AI tools to help in that patient counselling process. And so in conclusion, presacral tumours are very rare. They are complex and life-altering, and no one centre or surgeon has that experience or wisdom. And it's really through this international consensus that we've brought that knowledge together to hopefully make a major step forward, both in towards consistency, towards high quality, and more importantly, towards better outcomes for our patients. Thank you.